All right, welcome everyone. It is my pleasure and privilege to introduce our two webinar speakers today. We have Dr. Beth Neil from Temple University. She is our program director of the MSAT and the DAT programs. She has a lot of practice in creating simulations and then also has some publications related to this. And we also are excited to have Dr. Zachary Winkelmann, who is a clinical assistant professor in the Arnold School of Public Health at the University of South Carolina. He is currently the director of clinical education for their post-professional athletic training program and has his bachelor's degree from Texas Lutheran University and his master's from Indiana State and his PhD in curriculum and instruction from Indiana State as well. He is a certified athletic trainer, just like Beth, and a researcher with 137 peer-reviewed publications and several national and international presentations focused on telemedicine, sim-based learning, patient-centered care, and mental health. So I'm very excited to have them present this to us today. I will be here monitoring the chat. So if you have questions and you want to stick those in the chat, I can kind of coordinate those at the end. But I will now pass it over to both of you. Thank you so much for joining us.
Thank you for that introduction, Amy. We're excited to be here today. And starting off today, one of the things that when Zach and I were planning this presentation, we wanted to talk about the idea that we are all in different places in our simulation journey. So really exciting that we get to look forward to Paley coming up. And some of us have been doing sim for years and years. And some of us, this is a brand new aspect to it. So we hope that throughout today's presentation, no matter where you're at on your journey, there'll be some tips and tricks that you'd be able to take away from this to be able to help push your forward as well as an interprofessional collaboration forward with some simulation. So a little bit about why Zach and I are here today doing this presentation. We were graduate students together at Indiana State University and actually did simulations and standardized patients as part of our education curriculum ourselves. As we moved into our PhD positions, it was part of our responsibilities to learn and plan. We got to work with a really big simulation center that worked with a couple different hospitals and medical schools in town and really developed a standardized patient curriculum for the athletic training programs, as well as interprofessionally getting to work with a whole variety of professions during our time as graduate students. We've both since gone to different universities that are both in an accredited College of Public Health, which is a really cool connection. And both have really been able to jumpstart the standardized patient curriculum and strengthen different simulations within our athletic training programs. So we have brought some different things that we've learned along the way. It's going to sound like there's a lot of good, and there is. Know that for as many good things that happened here, we've had mistakes happen, blips in the road, and things that we've been like, we could have done that better. So we're sharing all of this, but know that there was definitely quite a lot of mistakes and trials learned throughout. So today we're going to talk a little bit about some terminology because we want to make sure that we're all on the same page as we begin. We're going to talk specifically about getting simulations ready, standardized patient encounters ready, and engaging our students and our participants. And then as important as it is to build the case, when we're building this, we need to make sure that we build and match a proper assessment with the simulation. So that's going to be how we end today's time. We want to make sure as we set the framework for today that we talk about the totality of the complete experience of a simulation encounter. And in looking through literature in multiple professions, we often hear people focusing on that actual simulation. And while that may take the most time planning and organizing and creating cases, we know that the entire time of that pre-brief situation to the simulation to the debrief is going to be necessary for the student to gather the information they need to really make the learning, to have that opportunity, not just from a grade, but from an actual meaningful experience. So as we talk about this today, we will focus a little bit on the pre-brief and debrief because those will be important to set up as we create those simulation cases. I'm going to hand it off to Dr. Winkelmann to go ahead and start talking a little bit about thinking about our design.
Thank you, Beth, and thank you to Temple for inviting me to be part of this webinar today. So to get us started, we're going to talk a little bit about preparing the design. Next slide. The first part of this that we need to really kind of focus on is your needs analysis. You're going to see some graphics in our PowerPoints as we go through, and these are from the INACSL, which is the Nursing Simulation Learning best practices. So you're going to see these graphics that are displayed here for you to kind of guide you through that. When we're starting to design simulation, one of the best things we need to do is sit down as a faculty and decide what are the things that we need to do for us to be engaged as a faculty outside. Input is also really helpful. So the other information here that we need to do as a needs analysis, or what are you trying to do? When we're thinking about this, is what is the guide or the area that we're really hoping to achieve? The discussion here then is about, why is this an issue? Has this been something that your clinical education sites have come back to you with? Has this been something that is a new standard added to your curriculum? What is the thing that really drives what we're trying to do in terms of why simulation is needed? Is it a program area deficiency that we're seeing on board exams, things like that? And then what are you wanting your learners ready to do? When you're designing simulation, a lot of times we think about that as a psychomotor skill, something that you do. However, simulation-based learning is a really great time to also think about affective skills, teaming, and cognitive skills. So thinking about how we can think about collaboration, communication, handling difficult situations. Simulation is a great opportunity to do those as well. And so needs analysis need to be your first spot to create the objective and why there's a need for this in your curriculum. So ways that we can do this are through a bunch of simulation modalities. So there's a lot of options that are out here, and we're gonna just touch on this briefly here today. And then this is a great way for you to continue to develop yourself as a simulationist. So commonly, we're gonna talk about things like standardized patient encounters, hybrid simulations, like in the picture. A hybrid simulation uses a mixture of a live patient actor with a part task trainer, which we'll describe a little bit later. So you see in this picture here, this person has a fake arm added to their body, and so their real arm is tucked into their shirt. And so this allows for us to practice suturing in a as lifelike situation as possible using simulation. So a person's still there, they have to talk through the situation that's going on, but they're allowed to still then practice the skills that we need to do. We can also do online, virtual, and distance telesimulations. We can do these in a bunch of different formats and ways, through virtual reality and augmented reality, through Zoom encounters. And this became very popular during COVID, but it has an actual skill and practice built in of teaching telemedicine and telehealth while also practicing our skills as providers. We can do things like time in and time out scenarios where as we do the simulation, we pause as instructors and say, time out, let me give you some information. Or the students can say, time out, I'm stuck, what should I do next? And so the simulation is more about learning rather than about grading. You can also do teaching simulations. This is a great way to integrate simulation into your coursework, where you bring in a content expert to guide a patient case for you, and you're watching model best practice happen, and the students are then able to stop and ask discussions about what that looks like. And then we also see ways for collaboration, things like disaster preparedness simulation or mass casualty training, where hospital systems can commonly work together to achieve those outcomes. Now there's a whole bunch of other cool ways also. We can do things like incognito SP encounters, which I've had some experience with, where you take a patient from the real place that this person is going for clinical experiences and train them to actually be a patient. So they're portraying a case the same way your standardized patient would, but the person doesn't know that that person is coming as their SP that day. So it's blinded, it's incognito to the person at that clinical site. You can also do things like voice simulation to practice auditory hallucinations or things like that. Training on the job, where we're doing simulation in the place the clinicals are actually occurring, which we call in situ. And then progressive simulations, where a person in simulation is often a one-point encounter. And progressive simulations really guide us through start to middle to end of our patient encounters and engagement with that person. And then as we start to think about, then we've got our needs, we've figured out kind of our modality, we also need to think about our timeline. we really encourage you to start backwards. Have your date set. So for example, I'm preparing my simulations for this semester, which are on April 15th. I started planning these in January. And so I'm working backwards from my April 15th deadline. From there, I've scheduled a space in January already. I've already created my case. I've tested out my case in previous courses and previous years. This past week, I've gone and hired and reached out and hired actors to portray that case for us. And now I'm getting everybody on board that's going to be evaluating and moving forward. So that process does take a while. This isn't something that if I want to do a simulation next week that I'm like, all right, let's just throw something together. It really does take a lot of time and practice. It also encourages you to think about your syllabus planning ahead of time. A lot of times we put simulation at the end of our classes, and it doesn't always have to be that way. Simulation can be about practice, can be about growing and developing. So you don't need to always put it during your finals week to make it a meaningful learning experience.
Sorry, I couldn't get my unmute button to go. I'd say the one other thing that I think is really important too, as you're thinking about that planning, is when is the time for the debrief? We'll talk about the debrief a little bit later, but making sure that you've built that in a meaningful time, that the students aren't having to wait. Like if you have a once a week class, you don't want them waiting to the next week to do the debrief. So making sure your schedule can work fluidly together. We're going to talk a little bit about the case development here. And as we head into this, I want us to pull the mantra of think smarter, not harder. So as we're doing case developments, really think about the idea of what is going to be best for our students. So Dr. Winkelmann talked earlier about maybe that needs assessment. So where are some of those curricular potential gaps that students aren't seeing things in a clinical practice setting? Or where are some things that you need your students to get practice on in a safe environment before they go into their clinicals or see some of those aspects in their clinical setting? So thinking about things like a simulation repertoire. So we have a group of athletic training educators that we share a bunch of already prepared cases for. And so rather than always having to recreate the wheel, I can reach out and be like, hey, Zach, I need a case that is X, Y, and Z. And sometimes it's nice and that others have already had them and will allow you to have those cases then. We've also collaborated with other educators to get to that same approach. We're going to talk a little bit more about real world here in a second. So I'm going to skip number 2 for now. But thinking about the idea of collaborating with simulation staff and subject matter experts. Sometimes you might be collaborating and coordinating a simulation that is not your main content area. So finding experts in your field or adjacent fields that would have that information, and working with different simulationists and simulation staff who have been around different sim cases to see what works, what doesn't, and really build that case. And also think about patient cases from either your preceptors, published studies, things that your students have done. How do we make these cases the most realistic? Because that's what's going to help the students the most. Our goal is not to create the most random case and have 25 things thrown at students, because that's not how real life works, and that's not the purpose of simulation. We wanted to highlight an opportunity that Zach and I did and were able to publish as part of Scholarship of Teaching and Learning. There was a lot of cases happening right around the same time of athletes having rhabdomyolysis and being hospitalized for that. And so at one of our regional events, we put on a large-scale simulation with multiple athletic trainers, multiple patients with some different conditions, and mimicked this based off of the real case. So we took this Iowa football case where the athletes had done a workout, got sick in that appropriate time period after, and did that simulation with them. And so we didn't actually have to create any of the actual scenarios of what happened, because we used something that had already happened. We're not going to get into this today, but just as a plug, this is a great opportunity too, as you're doing these. We're doing a lot in our college to recognize the Scholarship of Teaching and Learning. Utilize these simulations that you're doing as different ways to be able to publish some of that work. So as we think about case considerations, I did mention it earlier, but the idea of making it real is really important. So sometimes we get eager to, confuse patients, to throw, like we like to call them the zebras of like, what could be the oddest thing they might see at them, or how many different comorbidities can we do? And while sometimes we do want there to be a little curve in some of the sims, That's not always best case. Our first standardized patient that our athletic training students do here at Temple is a straightforward grade 1 lateral ankle sprain. It's one of the most common injuries they see, and we do that so they get comfortable with the idea of standardized patients. They get used to the idea that like they don't always have to find something that they learned could be one of the 12 random things that happens to a patient. We want to make sure that we have very explicit details for our students. We will script some stuff a little bit later that we've done to be able to help with actors, to help with students. We don't want them worrying about where to go, how to do things. We really want them coming prepared, thinking like this is what clinical practice would be like for them. And one of the things as you're working on this is a very scripted opening statement. So in dealing with any live actors or anything where you will have interaction with different types of mannequins, make sure that you have a scripted opening statement that will stay consistent for students. We know that the time in the sim can and should change based on the care that's given, but making sure that all students have that initial same opportunity is going to be really important.
So I want to highlight really quick on that last picture. Could you go back really quick, Beth? So as we look in this picture here, I think this is where we think about how you can design simulation based off your training as well. So the picture on the left is of a inside of a facility with we're going over a heat illness case here. We have exact same things that are in the picture on the right, except that heat illnesses don't typically occur in a cool air-conditioned environment with everything laid out perfectly for you. The picture on the right is how we've handled simulation, not always needing to be in a simulation lab, that you can do these things in situ or in the real environment. So this is one with real water, real temperature gauges, real blood pressure cuffs, real sweat. So we make this as real as possible. And that's really where the learning really happens. And so, Beth, you can go on the next slide. The information here that we talked about was getting that idea of an opening statement and creating your case. So the way that we have designed our cases, regardless if you're doing a mannequin, a standardized patient, or any of the options that we've talked about, the biggest thing is creating a case for yourself. And so to get into that piece first, we often go through kind of this similar rubric here. So what's the name of our case? Depending on that, we typically think about gender neutral names, things like Jamie, Taylor. We often pick for the names of the patient. That helps us then if we have male or female or non-binary actors, the person can portray that condition without needing to change the name of the case. However, sometimes we do have a case that is gender specific, like a woman, and that we may choose a name that represents that better. We also then explain the chief concern, and we make sure that chief concern is directly linked back to the opening statement. Why are you here today? Thinking about how a person would introduce themselves and what would be the first thing that person would ask. Sometimes we start simulations by a person rushing in or saying something, and so we need to set the tone of what that person is asking or needing help for. Sometimes it's a team-based cognitive skill, and it's like, hey, I heard that this is happening. Could you tell me more about it? And so this doesn't always need to be like, my arm hurts or my pain is this. And that's really kind of getting us idea of that chief concern and your opening statement need to be linked together. Then we need to think about what our appearance, what would we want them to look like? What clothes do we want them to wear? How do we want them to be dressed? What do we want them to have with them? We also then need to consider things like past medical history, thinking about the questions that may come up. So, do they drink? Do they have allergies? Do they have any recent hospitalizations? This is where it's helpful to kind of create yourself a guide and fill this in each time. And this is what Beth was talking about, signal versus noise. Signals are things that we need people to know that's going to cue them into maybe something that relates back to this. So this one, a person has a rash on their face and they're allergic to tree nuts. Those are signals that a person should say, if there's a rash, is there an allergy to the tree nuts? And that's what the rash is related to. The opposite of that is noise. So what if we have this person as a tobacco user or social drinker and has been hospitalized 7 times? It has nothing to do with the case. And so that's what we call noise, and that it really doesn't relate back to what we're trying to do. We have started to integrate the social determinants of health in our case development, so thinking about the background of the individual And we usually list this out to help us guide what is the bigger picture of this person and the community they live. This has been a great addition to our SP training guides as we think about insurance, the location, their education, their social support system, and helping us to guide some of those extra questions that may be asked. Moving into there, we also list out the history of the present condition. So where is it at on their body? What's the intensity and quality? What's the onset? Oftentimes we use like a PQRST or Socrates or one of our history taking mechanisms to really list out that key data that a person would need to present with. And then finally, physical exam. Sometimes this can be the hardest part, and this is where we'll talk about some opportunities you have in the future, but this is where we need to think about inspection. What should the body look like? What should be their vital signs? When a person presses on certain parts of the body, should it hurt? And this is where the actors need to understand that. So imagine you have a case where a kidney stone, I need to teach them that the patient or the practitioner may come up and tap you like this. If they do that, you need to wince or make a face or say ow or jump off the table. And so you're training them that not just that my back hurts, but how to react when those things happen.
That can I add here? Can you talk a little bit about, so, we kept pretty much the same format for most of the SPs. There are some time or I should say in general, just simulations too. Sometimes as we think about some other disciplines or some other aspects of cases, we had to adjust that a little bit. Could you talk to that effect a little bit?
Yeah, I have some examples of some ortho ones coming up in a little bit, but these areas we may have to think about also as you work with different providers, some of the questions or terminology they may use. So we've done some simulations with social work, and they typically do motivational interviewing to kind of get the conversation started. So we've created a box specifically for motivational interviewing because we know that's part of the routine. Same thing, we've worked with physical therapists in the past, and they typically do a red flag assessment that maybe not all professions do. So we've added in those questions specific to a red flag assessment. So when you're doing this, understand that this may be specific to your discipline, or if you're doing it collaboratively, you may need to work to understand what does a typical routine assessment or evaluation look like. And so also make sure you train your person. So whoever you have to portray this condition needs to then match up to what as the visualization of it. So this is the same case kind of translated. So this person had this rash that came up on their face. And so this is listing here the rest of that training guide from the first two. So this is the bottom. Is there any training or nutrition dietary things that we need to be mindful of? What's our differential diagnosis? Oftentimes, we may list other things here that a student may think is going on. What are some special instructions? What are some things that if a person asks you this, remember that this is a key part. So um, this instructions for this case, which is the picture on the right, was be eager to get the stuff off your face. I don't want this here anymore. That's the, I'm here because it's on my face, but I want it gone. So that's what I want you to help me do. Um, be adamant that your partner has no signs of herpes or cold sores. So over time, we've talked to healthcare providers that, like sometimes this looks like a cold sore. And so what if that comes up in conversation that could this be an STI, and how to react in case that comes up in conversation. And so we're basically preparing for whatever could happen in that special instructions. And then finally, the last couple boxes are just to kind of hold people accountable. Who is this case designed for? Who are the case authors? Who reviewed the case? And what was the date the case was created and revised? So Beth talked a little bit about how we've used some cases. The case of the grade 1 ankle sprain that Beth has used, we've used for probably 7 to 8 years now. We used it as part of our master's degree. I used it then in my dissertation, and then she's using it now at Temple. It has had several variations of that case, but the kind of constructs of it are still there. So this is a great way you can add the reviewers and revisions. So the actor on the right, or sorry, the actor on the right in that picture has a pustule on his face, which is indicative of impetigo. So we created that using bubble wrap. We inserted some lotion that was dyed yellow, and then used some makeup to match that kind of visualization on the side of the face. So rather than just saying like, yeah, there's a bump on my face and pretending it's there, the students would, as you can see, he has a mask on that's hanging around his ear there. They would take off his mask and they would see this. And it was really interesting because that was when the students reacted. They're like, oh my gosh, because they weren't expecting it to be there. And so then the patient reacted like, oh, is it that bad? Like I told you I want it gone. And so it's less about over dramatization and more about like, what would you do if this was actually you being the patient and your doctor, physician, AT, whoever reacted this way. And so that's how we train our actors is think about this is really you. What would you do if your nurse reacted that way? And then lastly, to kind of wrap up on this area, as you prepare your case, this is an example of an orthopedic case. So as Beth and I were kind of sharing about how stuff changes, this is a good example where this is more of an orthopedic-based case. So we may need to include things like gait, range of motion, selective tissue testing, neurological exams, palpation on the body. And so those are areas that you also then need to train your person what those feel like. And so when we're doing this, it's helpful to show them either links or videos. So for this example here, this is an ankle sprain case that we use. We often pull up YouTube videos and show them, this is what this will look like, or we demonstrate on them and show them when they pull your foot this way, this is when it hurts. So it's less about the name of the special test or the thing they need to do and more about anytime your foot goes like this, that hurts. Anytime it goes like this, it does not hurt, rather than Kliger's is painful and Taylor tilt is not, because that's not important for a person to remember. It's more about directions where it hurts, things that they need to match up as the case goes along.
So earlier on, when Zachary was outlining some of the different types of simulation, we wanted to talk about a few of the different ways to portray the case, because this is going to be a really important part of your planning. So we have a few different options here. We're going to start with simulations or a simulator or a mannequin. We'll talk here in a second about part task trainers, which is a slightly different aspect. But these are going to be these large full body mannequins that you'll see. If anyone's come down into Pearson 13, you've probably seen ours or EMSs sitting in a position, and it's probably scared you because they look like people. And so these are going to be able to go from low to high fidelity. So what this means is, for example, we have one in our classroom that is a mannequin. It cannot do anything special. It is just there. It is heavy, but it looks and feels like a person would. Exciting in some of Paley, and I know a lot of our nursing faculty have had some great experience with this too, of getting to work with simulators that are high fidelity. So these can go anywhere from being able to talk to you, to be able to have controllers go through and change like heart rate, respiration, blood pressure. There are full-on simulators that can mimic a person giving birth. And so these opportunities to really resemble high fidelity, and so that ability to transfer of what things would and could look like in clinical practice. The higher the fidelity too, the more you're able to actually react to how the students are doing in the case. So if a student is not doing CPR correctly, you have the ability on these high fidelity mannequins to adjust the vitals or not create any vitals from a CPR case that the patient would not revive in that situation, or vice versa. If they're doing well, you could make it that their efforts did have a positive outcome there. Standardized patients, which we've talked a little bit about from like a case perspective, these are going to be people who are hired and trained actors that portray an injury or illness. So it's really important as we think about these standardized patients, this is not just somebody coming in and being like, hey, my ankle hurts, can you evaluate me? These need to be people that the students do not know, or if you want the student to have some sort of relationship with them to like build on a prior case, that it's done appropriately. So this is going to be where it's important that like in athletic training, our other AT faculty members are not coming in and being the standardized patients. We have had it that we've asked for faculty around campus and they've come in because they maybe haven't interacted with our students, and they can portray that case without the student knowing who they are and having either that pressure or that ability to what we call suspend reality. So can they put themselves to where they really feel like they are in the clinical practice setting? Which is going to be a huge important part of them buying into and really seeing the connection of how simulation can mimic their clinical practice and can actually be beneficial for them. The idea with standardized patients, these oftentimes we do hear the concern of, I don't have a budget. How am I supposed to pay for these students or these actors? And each program is going to be different. Sometimes programs do have that ability to pay actors, and it's important that if you are paying them, that you pay them at the appropriate rates for what they're doing. One of the things that we have done within the athletic training program, because I do not have the budget to do this here, is working with undergraduate students in public health overall, kinesiology, exercise science, health professions, for example. And so these are students that do have a little bit of health background, which is nice. And they're really eager to get to learn, to get to see what standardized patients are. And they have been some amazing actors over time. There is a little bit of concern. We've had to do a really good job of documenting who some of the different actors are for our students, because we have then had some of those join into our program. So it is important that if you are doing this, that you keep a good record of who your patients are in case that does happen to you. It's a really positive piece, but does create a little bit of a wrinkle that they would know the case. And lastly, one other thing that I've done in that time to kind of thank them is I have offered to write letters of recommendation for them or a letter stating that they helped, which has been helpful for some graduate applications. So just little ways that you can think about that coming back. And lastly, we want to talk about role play because we know that this happens a lot in education. There is a time and place for role play. So when you go in, either students create a case with each other, faculty come in and they're like, oh my goodness, I broke my leg, and just like fall on the ground. These can have some good learning opportunities. The students probably can practice some of the skills, but this is not a true simulation. So it's important that as you're thinking about this role play, again, it has a plan and a purpose, but making sure that we do understand the separation and differences there. Much like the simulators earlier, there are part task trainers, which are going to just be portions of the human body. So we use a lot of these from a general medical condition to be able to look in the eyes, the ears. We all do them for CPR. Zach mentioned earlier about the suturing model that we could put on a patient. And so anytime that we have the ability to pair a part task trainer with a person is going to only increase the students' ability to make this feel like a real case. Sometimes students will buy into this and be able to understand that they're still being able to learn and practice, but sometimes we do recognize that there can be a gap in certain students buying into these part task trainers. They do come with a little bit of a cost, but they are a really good educational tool. And some of them you're able to actually change and make certain conditions and things like that you could have the students identify. We really want to focus and making sure that students have the ability to make this as close to clinical practice as possible. So integrating moulage, Zach, here's a picture here of a laceration. He showed the skin condition earlier. Oftentimes, I feel like this is a place that people think are really expensive or they don't know how to do. Use things around you. Moulage kits on Amazon are under $20 too. I don't want to speak for sure, but I would imagine that having a system like Paley, some of this would already be built into that place too. But we also have utilized things like expo markers in creating different types of bruising to be able to like smudge it, trying to, wet it down a little bit, makeup, eyeshadow, things like that. Be creative. Zach mentioned the sound sites indoors, outdoors. It'll be really cool in Paley for the immersion room, getting to adjust what's around us for certain sounds. Like from an athletic training perspective, the loud noise of a football field to the hush when somebody gets hurt is a really emotional experience. For people in a hospital setting, you could have the noise around you from an emergency room or the beeping of like an ICU unit being able to continuously go off. So that way, it's not going to be a nice quiet room typically when you're doing some of these skills. Being able to think of like indoors, outdoors. So what can we take outside? What would be outside for some of our different professions? And so really thinking through where the best location for this is going to be. This is also an opportunity for us to think around the sim center, maybe getting out of what's more of a structured office and going to the community park, going to the in the row home in there. It doesn't necessarily have to be outdoors, but we have a huge simulation center with different places that would mimic some of these real life scenarios. And it's also important to think about interdisciplinary as well as different collaborative situations that you can do. So, what is your expertise? What is maybe the expertise of another profession that they only help your students? What would be a natural thing that 2 or 3 or 4 health professions would work together? And it's really important as we do think about this as interdisciplinary or interprofessional collaboration that we are thinking about things that truly would mimic real life practice. So not forcing interactions that wouldn't happen in the healthcare field. And we also want to think about who are some of those maybe, like I realize there's been a lot of focus on clinical programs with this, but who are some of those other disciplines that we have in the college who would be helpful for different aspects? How can we integrate, Zach mentioned social work earlier, how can we work with health informatics to have our students create different things to help the patients, to help the clinicians, things like that.
I wanted to add here too, Beth, really quickly on the collaborative sims, that collaboration doesn't always need to be multiple professions. It can be multiple students from the same profession. And so thinking about also the idea of maybe this, we just did a drug overdose management simulation. At no point should someone manage a drug overdose by themselves. And so you need to have someone for cardiac and respiratory compromise, and calling 911 and the full care. So why would we do that disservice to one student, expecting them to take care of that? And so we created those as teams of 3 people, knowing that this is what best practice should look like when you're doing it. So let's practice best practice when we're doing those.
Thank you.
Yeah. So kind of moving in and adding on to what Beth was talking about with fidelity, is also the idea of inclusive simulation. And I know Temple and some conversations I've had with Dr. Manzel and Dr. Neil has really taken an effort in this area. My program here at South Carolina has too. And I think this is an area that you can be really easily skipped over when you're designing simulation. So think about stuff that goes along with the case. That stuff is really important. It's the things that make a person who they really are. So consider the case background. Do the cases then either stereotype a person, or does it reflect typical presentations of a community or a person from that background? Consider the names, the ages of the individuals. If we have a 15-year-old patient, is the name Ethel going to be most common? Probably not, right? It's not a common name that's used. And so try to match when we're creating names to your patient, to the patient matches their background in terms of race and ethnicity. Is there a reason why this person has this condition? It helps also the fidelity of the case. So for example, if we have something like a sudden death from a cardiac abnormality, we typically see those in African American young men. That would be a really good way to create a case that is a Black male, that we then have this case that maybe plays basketball, and it's not stereotyping, it's using your epidemiology and your stats and your background to then guide a student to think this person matches our typical at-risk population. So we need to have that to kind of match that for your case. Other things when you're just practicing for simulation, I've used these tattoo sleeves that you can get from the dollar store and put them on IV mannequins. And so using those to help the students practice, like if you have a person that has a lot of body art, maybe that would be more difficult to start an IV on, what that process would look like. We've added breast additions to our CPR mannequins in the third picture here. This helps students to think about how hand placement would be for a person, for a woman when they're doing CPR. Think about our mannequins. They typically are all the same size. So think about child mannequins that are a little bit smaller. We have one that is age 5 and an age 9 mannequin. And so we can practice doing youth care for those. Weight and body size, but also skin color and age. All of these are important not just for your live standardized patient actors, but also the mannequins that you're getting. And then finally, my last note is that if you're going to hire people and it's going to be about a specific group or community, hire from that community. We did a case here focused on transgender patient care, and it is really important that we hire somebody that identifies as trans to portray that case, rather than hiring someone that doesn't actually know the lived experience of the questions that may be asked, how they would react, the legal and gender affirming care that a person may go through. So hire from the community. To do so, we used our community, our Office of Multicultural Affairs Center on campus to find individuals, share that experience, and then take breaks throughout to check in on that person as they are going through this experience too. We're going to move into some planning process now. So now that you've designed your case and you've kind of thought about all the pieces that fit in together, we often use a simulation planning form. So this is in addition to your SP case or your patient case. This helps us to work through the day of. So what's the date? What program is this for? Who's going to be my contact person? Who's else going to be involved? How many learners am I going to have? How many simulated patients are going to be there? What's my method of debriefing? What type of modality did I decide to use? And what sim staff or other people do I need? This helps you to start to plan all the pieces. And this is what I typically do about 4 to 6 weeks out, is start to run through each of these areas. This here then helps me to align that what's the summary of the case, how do I want the room set up, what supplies do I need. So this almost creates a checklist for myself in terms of the things I need the day of and who I need to communicate with moving forward. Other things and part of that planning form is a timeline. Timelines can adjust depending on if it's a live actor or a mannequin. The timeline is essential when you're doing high fidelity mannequins. That essentially says, like, if this happens, do this. So for example, our drug overdose simulation we just did. After 2 minutes, the person was meant to, if they provided Narcan, the person was supposed to start breathing with agonal respirations and a pulse was meant to be felt. However, if a person didn't provide that, we didn't have that in the timeline. So it cued our sim staff to know what to do at certain timelines. You as the healthcare provider, the educator, need to help the sim staff know that. So if I do CPR, how long is the typical response time? If I'm meeting with a person for motivational interviewing, how long is that timeline going to take? If I'm going to do a physical exam on a person, how long does that typically look like? 15 minutes, 20 minutes, 3 minutes? And so planning from there and then expectations during that time. That will also ensure that you have not put too much into an encounter. Sometimes it's best to segment things. So Beth talked about their first encounter at Temple is a grade 1 lateral ankle sprain. My first encounter for our students here is only history taking. And they have 10 minutes to practice just history taking. And it's one to get them in front of a patient for the first time. And I don't want them to do anything else. At no point do you need to touch the patient, evaluate the patient, or do anything else. Just talk to a person. And that can simply be a simulation in itself. And so thinking about how long that you have and how long do you need. Some simulations run an hour. Some simulations can be done in 2 to 3 minutes. And so it doesn't need to have a specific timeline associated with it. In addition, think about complications. What could go wrong and plan for that to go wrong. The AED batteries stop working. That happens at least once a year to me. The blood pressure cuff is not inflating. All right, how are we going to navigate this? The patient said something that they weren't supposed to say. How do we now move forward? Think about those complications that could pop up, but also if a complications are the things that they said that the patient or the sim staff needs to respond to. So imagine they referred out to dermatology in this case, and they didn't need to. They need to be going to see their primary care physician for antibiotic. What does the patient then need to say? So we are training them on the complications or the unexpected as well. And then lastly, our expected learner response. Hopefully they get the correct diagnosis or provide the correct treatment or management plan. What would be those successful actions that we talk about: allergy, sexual activity, pets, things like that, and things that we don't want to see, that bad reaction, as I talked about when they took out the mask and like, oh my God, what is that? That's not the reaction we're hoping to see. And so those are the behaviors that we need to ensure line up with our assessment forms.
The one other thing too that comes to mind with that learner response is thinking about the case that you're doing. So, something with a skin condition, that might be with how the student reacts. We're actually prepping for a standardized patient here in, gosh, like 2 weeks, I think it is now at this point, where the patient has suicidal ideations. So in prepping for that, we have actually reached out to our chair to make sure that they're aware of the situation. We've reached out to Tuttleman Counseling just in case we have a student who has a negative response to that. So just that way we can have that plan in place, because we'd rather have it and know what we're going to do as faculty than day of trying to scramble.
Beth, do you remember our mass casualty simulation? We did one at
Yep.
Indiana State together where we had a bus crash, and
Yep.
it was a university bus, and so people were like, "Oh my God, what's happening?" But we had to set up cones and signs that were like, "This is a simulation as you walk by," so people don't think a bus crash actually happened. We also contacted public safety, so in case someone's like, "There's a bus crash," that public safety is like, "We know it's a simulation." So think about all the other people that could also see those things.
We mentioned pre-brief, and just as important as the actual time, we're not going to get into today some of the different tasks that you can do with students in pre-brief per se, but from a preparation and case creation standpoint, it is important to have some sort of pre-brief that's going to go out to students about 1 to 2 weeks beforehand. So we use the same template here where it is very explicit of what is happening, where do students need to show up, where do we want students to stay? So for example, when we do one of ours that are actually in our offices, we have a very specific space where we ask them to, please wait on the Ritter floor open area. And we have signs in that area too. We tell them which elevators or which stairs to use. So being explicit to take away some of those fears that day of could happen. In thinking about this, this also gives them the idea of how they will be assessed. So we'll talk about assessment a little bit later, but we know that no matter how many times we tell students it's about the learning opportunity, they still have that little piece of like, well, what's the grade? How do I get a good grade on this? And so really working through trying to think ahead all the different aspects and things that students may need to have prepared. And I really appreciate this in writing. That way students can go back to it. And then I will reference it in class as well, so they have the opportunity to voice any concerns at that time. In thinking about a few of the different aspects of it, this is a couple other places I mentioned the idea of like where they're going to be, what they're going to do. It's going to be really important as we think about a new location that we bring the students to the location. For example, we are doing this location in Bell to be able to get to try some different things this year. And so I'm actually taking a portion of my class one day, and we are taking a field trip from Ritter to Bell to be able to have the students get to see where their area is, and they don't need to have that extra concern. Thinking about what's around. Zach and I were talking when we were prepping about the idea that in one time he told them like, hey, I have an athletic training kit available. And all the supplies were in there, but as you open the kit up, they didn't know where everything was, and you would know where things are in your kit. So giving them that opportunity to go in there, take a look at the kit, see where supplies are. Early on, I made the mistake. I had the supplies at one end of the table and thought I was so nice and had everything out, and the students didn't turn their heads a little bit, which is my fault, and so they didn't use some of the tools and supplies that they had. And so the one other thing then too is thinking about confidentiality. We are going to be doing multiple cases. All of your students can't go at once. So really having students understand to please not talk about this case. Keeping the debrief a time, like we don't even ask our students not to talk to each other afterward, because we want that time in the debrief together to be that organic. Let's talk about it. What did you learn? How did things go? Over time, we've changed a lot of things for the better because of a paper that we were able to help on, which was specifically about athletic trainers' perceptions of anxiety before, during, and after a standardized patient encounter. Students really identified that they were fearful of being judged and like by the people who were grading the situation, being worried about overwhelmed. The uncertainty piece, that pre-brief form is way better today because of some of that we got of the uncertainty for them. Little things like the first time we were in there, they didn't know that the sim capture cameras, when they moved, they could hear them. And so that was like panicking students. Or early on, before we had cameras and we were writing stuff down, even if we were writing positive things down, it scared them because they just saw faculty members writing. So now if I have to be in the room with students, I say, hey, I'm writing all different things so I can have notes of things that you did really well and areas that I want to improve. So thinking about some of those different aspects specific to your program. The day of simulation, we've talked a lot about this idea, but really knowing that making sure that we have things planned, planning for the unexpected, give yourself time before and after the sim as a faculty member, like block your schedule. You don't want to have to be somewhere 15 minutes afterward. You're not going to make it there on time. You're also probably emotionally not going to be ready to do it. So just really making sure that you've set yourself up for success on the day of simulations, as well as the students. And lastly, we want to talk about the idea of getting the background for the encounter. So a few different ways that you can go about this and really setting up this pre-brief. So sometimes we'll have pieces of paper on the door that the students are able to see. We've done it to where you go in and get to watch a short video of the patient or of setting the scene. Sometimes it's auditory only. And so really getting them knowing what's coming. Sometimes it's going to be important for them to know who's in the waiting room. So this example here, they're only seeing one of these patients, but we don't want to tell them at the time which patient it is. Be thinking about do they need to see a prehistory form that would have been filled out? Do they, if this is a secondary encounter, you would have previous medical documentation. So have that medical documentation available to the student, making sure that we're mimicking clinical practice as much as we can with this. And then lastly, the idea of debrief. We are getting a little bit short on time, so I don't want to rush through this, but I'm happy to even have further conversations with people. Setting up a debrief is going to be really one of the most important aspects of a simulation case. This is that opportunity that students can come in, they can get to talk amongst learners, faculty, other people involved in the case, and really get to learn. So again, this is a time that we don't expect students to do everything 100% correct in every simulation. In fact, it's actually a really cool thing to go through the simulation, have a debrief, and allow the student to do that case again. So get to walk through the steps that they didn't do an IV insertion correctly and get to try that again, so that way they don't just hear the steps, but they get to then practice them right away. These can be sometimes really emotional times for students. So being able to manage that as faculty, being able to curb and understand expectations of what students think they should do, while providing the idea of what sort of things that they can learn, take away, apply to their clinical practice. There are tons of different debriefing methods out there. So it's going to be really important that you determine what is best for you, what is best for your curriculum, and get really good at that. I also really value the idea of that not all debriefs have to be the same amongst cohorts and classes, but it's really nice when the students kind of know what's going to happen in a debrief. They're much more willing to talk, they're much more willing to engage, and finding creative ways that, some students don't like to verbally talk in class. So how do we get them to share their reflection? Or maybe they need to be in a small group and they're learning, or maybe they write some stuff down quickly and submit that into Canvas with just the ability for them to share there. So coming up with ways, just like you all would in the classroom, to include all learners and not be selective. Certain people are going to want to talk a lot.
Beth, I'm going to add in here too.
Yeah.
Just to debrief is not teaching. Our goal is to not teach them the stuff that they just did or did not do again. The goal is of a debrief is for us to describe the things that we saw and learn what happened in their mind. That is the whole purpose of what we're trying to do, is facilitate a thinking about, I saw you do these things. Could you tell me why? I think what I saw was this, but could you tell me what your thinking was or your decision to do that? And so you're really trying to figure out what they did well, what they didn't do well, but also why they did those things. Kind of leading into that is our assessment techniques. And so just to kind of wrap up here for our session today, assessment of simulation can take a couple different forms. High stake, meaning a total pass-fail, a certification exam, a competency. Please make sure that your learners know if that's going to be a high stakes. That is the anxiety-inducing ones. We also have formative and summative. Formative with the goal to improve. We encourage you to do those throughout the semester and at multiple time points using multiple different modalities. A summative, typically at an end of course or end of unit. And it's typically linking multiple concepts together. So maybe through a course on orthopedic evaluation, they're now learned each of these concepts and we're putting it all together for the simulation. Some of these methods that we can do here are things like on the left, a patient assessment questionnaire. Have your standardized patient actually complete how they felt when they were being evaluated. My goal for these is when I give them to our actors is I train them that a 3 is a good person, a 4 or 5 is exceptional, a 1 or 2 is bad. So all 3s is really good. If you give a 4 or 5, write down why. If you give a 1 or 2, write down why. And that helps us to streamline the kind of efforts for that. The one on the right is an evaluation form that I've done where it's only note taking. So it's not for a grade and we're just providing notes. And so part 1 feedback on ortho, part 2 on diagnostic imaging, and part 3 on delivering bad news. Those notes on the left there are just for me to remember what I want to talk about. And then I take notes on the box to give thoughts or feedback. Other options, these are a combination of ones that Beth and I both used. You can see here a bunch of different checklists, right? A 5, 4, 3, 2, 1, a milestone approach where you are reaching certain milestones in the top right. And the bottom 2 are a checklist approach where performed very well, performed but didn't do it right, performed but did it wrong, or didn't perform it at all. I love that one because it kind of takes away the nuances of like, that was good or above average or below average. And it's like, yes, they did it, or they did it, but they did it completely wrong. And then the last one, the perform, did not perform. Those are really helpful when you have stuff that's like either yes, no's. If sometimes it's a yes, but I would encourage you maybe to think about your checklist to take a different approach there. And then lastly, our reflections. So I do a written reflection. We also allow students to voice record or video record their reflections if they don't want to write it out. We also have them go back and watch their SP recording. So watch their video back and then debrief or reflect on it there. We also do a really cool one where they watch their first encounter from the very first moment that they got in the program, and they watch it at the end of the program at graduation. And it's one of the coolest experiences. They're like, oh my God, I was really bad. And I was like, yeah, that day you thought you were the best AT ever. And they're like, oh my God, I've grown so much. So thinking about reflection, and if you're going to have students do reflection, teach them how to reflect. What is actual reflection in that process before we get going? The one on the right is from Beth in a SOAP note form. So documenting the encounter and putting that into a template for us to kind of move forward.
Thank you so much for having us. We'd welcome any questions that we may have gotten in that time.
Thank you both. That was amazing. I didn't have any questions in the chat. I did have some folks reach out and ask if any of your materials from today are able to be shared. So I think we've got some folks thinking about how they can start to integrate this into their own programs.
Yeah, I'll say let Dr. Winkelmann and I chat and we can see what we can pull from different aspects to try to have available for people and
Great.
get with.
Yeah, there's also a really good website called the Center for Medical Simulation from Harvard. I highly encourage if anybody wants to get more training in this area. I went through the course to do that, and it's from the Harvard Center for Medical Simulation. That's where a lot of my training and background I got really good at. And so I encourage you that if you're wanting to do some professional development, that's a really good place. And they also have a lot of these resources on their website there too.
Great, thank you. Any questions from our audience? All right, well, we only have like 2 minutes left, but I was wondering if you could just tell us, I think we've got people all over the spectrum here in our audience. If you had one piece of advice to give to some folks who maybe haven't done any simulation or they've done some low-level simulation before, one quick piece of advice, what would that be?
Don't let perfect stand in the way of you doing this, because I want everything to be tip top, and sometimes it's not going to be, and you don't have the capacity for that. And the students are still going to get a great learning experience from it.
I would encourage you to pick something that's entry level and really your area of expertise to start. and choose something that would be easy for a student to do and start there when trying to create something that's maybe higher level for yourself so you feel comfortable and a student can feel comfortable because you're adding a new modality that's difficult. So thinking about those two pieces when designing.
Great. Well, thank you so much. Thanks to all of our attendees today. We do have one question. This is probably more for me. Will your fidelity simulators be available in Paley? I will defer that question to the folks that are currently doing the ordering for Paley. I know that we definitely have different fidelity levels of what's coming in, but I'm not sure of what those actually are, Lori. But we'll find those out. All right. Well, thank you to our guests today, Dr. Winkelmann, Dr. Neil. Thank you so much. We really appreciate your time.
Thank you. Have a good one.